Dale with us here today to present Outbreak Management and Workers' Health and Safety for Community Support Services. Um, I will let Dale get started on his presentation.
Perfect. Good afternoon, everybody. Hope everyone's doing well. Hope everyone has a cup of coffee and something to eat for lunch because hopefully I shouldn't be too boring and make this somewhat exciting. So today's topic is going to be on outbreak management and workers' health and safety for community support services. The presentation is going to be outlining just I don't want to say the basics, but in between basics and general understanding of outbreak management within the community support services agency, things that we should look out for, how we respond to outbreaks and kind of what's going to be expected coming this year's cold and flu season. I like to call it outbreak season, but it sounds a little too heightened. So we're going to call it cold and flu season. Um, so far, we do have a few cases out there of COVID and quite a few outbreaks just by sitting in some of my committees, I should say, and some of the meetings I've been at or been to, and looking at some of the information that's out there. It looks as though this outbreak season or cold and flu season may be a very strong one in terms of cases. During the summertime, things were fairly busy. So I figured, you know what? Now would be a great time just to kind of get a brush up on how to manage an outbreak and things that we look out for and things that we do during outbreaks. So again, as I said, it's going to be a very basic to general overview. Outbreaks, and you're probably going to hear me say this quite a few times during the presentation. They're very fluid, very organic. There's so many moving pieces, and if we hit every single moving piece today, we're going to be here for hours. So this is going to be something that's going to give us a great overview of how outbreak is run and what to expect from ourselves and from public health, which in many cases isn't a lot because public health doesn't really respond to ADPs or community support services. They tend to respond to long-term care homes and retirement homes. So without further ado, let me stop boring and let's move on with this. Move on with the presentation. Next. From the get-go, I'm just gonna let everyone know I may take myself off of video, and the reason I'm doing this is because of connectivity issues. So please bear with me. If you have issues hearing me, please let me know, and I will do my best to speak up or to fix or correct the issue. So today, what we're going to be talking about is outbreak case definitions. We're going to go through outbreak identification and line lists. I'm going to try to be very brief on this, but the role of public health, the role of the employer, and then we're going to get into IPAC measures during a confirmed outbreak. And underneath IPAC measures, it deals with administrative measures, which is a criteria underneath that heading. Client, patient, resident restrictions, restrictions on affected areas and sites, so affected home, affected long-term care home, affected retirement home, or CLS, which we're not going to get too heavily into because I know we don't have a lot of LTCs here or retirement homes, but they are a big part and a big chunk of outbreaks in the community as well. We're going to talk about group and social activities, what is allowed, and visitors and essential caregivers, healthcare workers, volunteer. When I talk about healthcare workers, I'm going to get into caregivers, which is a big, strong component of this as well. Volunteer outbreak control measures are going to be implemented here, we're going to discuss. And then we're going to get into enhanced cleaning and disinfection, which I know we've done millions of times, but it's one of those things that it's great to have a overview, especially coming out of this summer season. Everyone's been on vacation. We lose a lot. It's good to get a little refresher as well, but we're going to get through that. And then infection prevention, workers' health and safety as well. Next one. Outbreak case definition. So yep. So just going to be very upfront. A lot of the information here is also pulled from the recommendations for outbreak prevention and control in institutions and congregate living settings and has been somewhat adapted to us as well. So you're going to know some of this information may sound very familiar, but it's a good way for us, again, to go and review some of the outbreak protocols and procedures that we're going to have to address when we move into outbreak season. So from the get-go, I'm going to throw a hypothetical situation here. We have 5 people with unexplained respiratory illness. What is it that we do? Now, every institution should have an outbreak plan. All right, sorry, I hate saying institution. Every agency or organization should have some form of an outbreak plan. And part of that outbreak plan is deciding whether or not people who do call in and say they're sick, or anyone that calls in complaints of an illness, be it respiratory or gastroenteritic, they meet some form of a case. So case definitions are typically established at the beginning of an outbreak. So if I know somebody has a positive laboratory confirmed swab for COVID, and it's about 3 or 4 people, I know it's going to be a COVID outbreak. If I have someone who's has symptoms that are indicative of Bordetella pertussis, which is a whooping cough, and there's specific symptomology for that. One person may have tested positive through blood. The other person got tested positive. The other person wasn't tested, but they had close relationships. There's a very close epidemiological link. There's a case definition for them as well. So the purpose of case definition is to ensure that cases are accounted for in a systematic and consistent manner to enable comparison and analysis of trends. And then again, in outbreaks, case definitions are used for counting outbreak cases only. They're not used for establishing any kind of clinical diagnosis. And to build case definitions for outbreak, it's often helpful to consider what is known about the outbreaks. So to develop that outbreak case definition, we got to know if this person is even a case. So there has to be a case definition for that person as well. Next page. Just to be off the bat, I'm not going to read directly from the screens. I'm not going to be reading everything verbatim, so I might give me an explanation about a slide. And again, just to let everyone know, you are going to be receiving a copy of the slide decks after as well. So just to keep you abreast with that. So outbreak case definition. Outbreak case definition exists when there are 2 or more laboratory confirmed cases. So for instance, I'm using COVID here, of COVID-19 or influenza A cases with epidemiological link in the facility. Um, Examples of reasonable having acquired infection in the facility include no obvious source of infection outside the facility, or known exposure in the facility or home. So outbreak case definitions usually established again to determine that we have an outbreak. I know with COVID, it did change a few times. It was either 2 or more cases, sometimes 3 or more cases. So sometimes also no confirmation via laboratory, but strong epidemiological link. I apologize, tongue twister. A very strong epidemiological link. And those criteria would establish an outbreak within an organization or an institution, be it long-term care home or retirement home as well. Next. Outbreak identification and line list. So we've established that we know what the cases are. We established that there are about 5 people that have been ill. Let's just hypothetically say out of those 5, 3 were positive for COVID. The other 2 were probable but strong epidemiological links. We do have an outbreak on our hand. Our plan was to, first of all, notify public health, let them know what's going on. And in a lot of cases with us in community support services, they don't say anything. They're just, thank you for letting us know. We're kind of on our own. So from there, we have to build some form of a starting point. What are we doing? We're going to have our outbreak management team put together, a group of people, representatives from our facility, from our organization, who are going to help out with this. We've already reported to public health. We're going to start line listing who is ill, who is part of our case, who's part of the outbreak. So we have something called a line list, which I will get into a little bit later. So again, as I mentioned, the outbreak identification is identifying that the cases are cases associated with the workplace or the agency. It either can come in as complaints of illness at workplace from the employee. It could be a request for assistance from an employer. It could be other provincial or government agencies that might say, you know what, hey, I've been noticing that, and sometimes the labs do this too as well. You know what? I had about 4 or 5 positives, swabs from someone from your organization or someone within your organization. They also said they worked at XYZ. Something's going on or something's brewing. So sometimes those are the ways that we understand that, hey, something's going on. Had a few calls. We had other provincial or other organizations that have updated us. Something's on the go. Let's formulate this line list so we can get a better picture of what's happening. So from there, we would put together a line list. Next page. We put together a line list. Yeah, thank you. A line list. And what this line list does for not just public health, but for us as an organization or employer, is it helps us to understand what's happening in this facility. Who's actually ill? And again, these line lists that are created all are used for ill staff and ill staff, ill clients, ill caregivers if they're a part of your makeup of your staff. Anyone that is ill within your organization goes on these line lists. People that are not ill do not go on the line list. This is only for those who are part of our case, who meet our, as I stated in the beginning, who meet our case definition. So a table that contains important information about each case in the outbreak. Each row represents a case. Each column represents a key variable such as a name, date of birth, age, room, symptoms, onset date, and resolve dates. It helps us to keep track of who's on the line list, who's gotten ill, who's gotten better. And what I love about line lists, for me, as an investigator, is it helps me to see a visual of what's been going on within this facility. It helps me to propagate or put together an epidemiological curve, which helps me to get a visual understanding of who's been ill, when they became ill, who's linked to who's not linked to who. If you're a long-term care home, what areas is the outbreak at? Okay, you know what? I'm seeing a lot of people on the fifth floor. It looks like it's confined for the fifth floor. Or I see a lot of people within this neighborhood if we're doing community support services. So there's something going on in this neighborhood where there's a lot of people getting ill. I'm going to take certain precautions when dealing with clients in this home, in this specific neighborhood. So it helps us to generate some form of a visual for outbreaks. Next. Again, it's going to be legible and concise. Client's cases should be on a line list unless it's a reinspection. So if the person is originally ill and they're off the line list, some cases, depending on the situation, if it's a reoccurrence or a reinfection, they would go back on the line list. If we sit down and say, hey, you know what, I think it's just the lingering of the previous infection, they still stay off the line list. Should be discussed and sent to your local health unit daily with updates. So if you're a long-term care home or retirement home or CLS, yes, this is getting submitted to public health daily. With us in community support services agencies, ADPs, if we're dealing with something that's suspect or something that's confirmed within ourselves, this is something that we keep amongst ourselves and we keep to ourselves and to our stakeholders within our organizations. Unless public health gets involved and they need to see it, then we'll send it off to them as well. And then as well as I mentioned, line lists are formulated for anybody, so staff and or clients or residents who are sick within the organization. So they have to meet case definition to go on these line lists at all. Next page. And again, I've shown this before in the past, and the reason why I like using this is a great example of what a line list should look like. It's very easy to read, easy to use, and it has institutions' names, lets us delineate whether or not it's a respiratory or gastroenteric outbreak that we're dealing with. So there's a different form for that. I pulled this one from Durham, but Toronto's, Durham's, Peel's, the one I've used in other health department, they all look exactly the same. Very easy to use, name, gender, age, onset date, which is very important, and symptomology as well. Any complications, specimens taken, prophylaxis as well taken, or the status if this person's resolved. So it's very easy to follow, very easy to use for our staff members, and it helps us out in getting a visual of what's happening within the facility as well. Next page. All right, so what I've done is I've put in a little question period here just to see if everyone's been following along with me. And it's just a quick question. So we're gonna have one or two of these during the presentations. So I just want you to vote on this. And the question is, what is a line list? Is it a list of names, symptomatic clients, staff, and patients, a list of names of all the clients, staff, and patients in your agency, or a list of names of employees who enjoy IPAC? And I'm going to give you about 10 seconds for everyone to take part. If you don't want to, I fully understand. Perfect. So A is the answer. A list of names of only symptomatic clients, staff, and patients within in the affected area of the organization or affected outbreak. So everyone's correct. Pretty much we got 25 out of 27, 93%, 7%, a list of names of all the clients. staff and patients in your organizations? I do see someone did answer that. That's fine. Typically, no. You will have your own list of your own staff and clients in your organization, but again, that line list is just primarily for those who are cases who are part of the outbreak. So more than likely, they're going to be symptomatic, they're going to be ill, they're going to show some form of symptoms, and they're going to be a part of the outbreak. They're going to be listed as a part of the outbreak. But great work, guys. That's really good. All right. Roles of public health. Now, I'm not gonna, if you can go to the next page, I'm not gonna get into this too much. The reason being is we know as community support services agencies that we would a lot of times when we do call public health for help, understanding their situation, they do not have the power or the people power to provide support for our outbreaks in our facilities or agencies. I know at the onset of COVID, there was that support, but after that, because of the amount of cases that we're getting, amount of outbreaks in long-term care homes, they kind of pushed us to the side and said, hey, you know what? As long as you have this checklist, you're good to go. You can report it. Doesn't really mean we're going to call and support you, but thank you for letting us know. But for the most part, public health and the role of public health during an outbreak is to receive and investigate reports of cases of contacts of, and I guess in this case, I use COVID-19. They investigate clusters associated with outbreaks and determine if the outbreaks actually truly exist. So they provide guidance and recommendations to the agencies on outbreak measures, determining when the outbreak is over as well. In some cases, they may issue orders via the investigator through the medical officer of health, which does happen sometimes. And they make recommendations onto facilities or organizations in terms of outbreak testing, what to provide for investigation, and they also provide outbreak numbers. The good thing with public health is when I know there are a few health units that I was speaking to some of our agencies. They said there are a few health units that are sending out investigators now to do quick spot checks, which is really good. And those spot checks really help out in terms of what to have in case you do run into an outbreak. So I know that public health does have us somewhat on uh, on the radar, I'd hope in some of the regions. In some of the regions, they don't have us on radar, but we're hoping this will change. It's been 4 years, and things are getting a bit better in terms of response. But again, as I stated, public health typically will not respond to an outbreak. They will just give us a quick maybe sheet to follow, or maybe it's a quick blurb on what to look for in terms of outbreak procedures and protocols. Next page. Role of the employer and workplace. So, the employer during the outbreak is to support the employee with any reportable disease illness. Know and communicate the rights and responsibilities of employer and employees. Ensure you have a policy that supports employees who need to be absent from work due to illness or be in close contact of a person with symptoms of an acute disease. Ensure all employees are aware of income replacement as well, which I don't get into. That is more or less an employer workplace issue. And employees are responsible to report the illness to the employer. So that's a big component there as well. If you're sick, you're not feeling good, report it. A lot of times, if enough of our staff report illnesses in time, as they should, you'll find out whether or not, hey, you know what, we got something going on here. So, let's take extra precaution to keep our staff safe and to also keep our clients and our patients or residents safe as well. So those are some of the responsibilities of the employer. Next page. Again, a big responsibility of the employer is ensure the area is clean and disinfected regularly as well or as soon as possible. Employees understand the return to work policies and self-isolation periods when dealing with the outbreak, which we will get into a little bit more when we talk about IPAC measures. There's going to be isolation periods. Someone has a reportable disease. There's a period of incubation, a period of communicability that we deal with as well. And our biggest thing is to ensure that that person is not around other people who are not ill during their period of communicability. So we get them isolated. But we'll get into that a little bit later on too as well. Another responsibility is individuals who have been identified as close contacts will be provided with isolation instructions and using the staff screening questionnaires to determine whether or not you can return to work or whether or not you can go back to work. And this is all based on individual organizations because I know every organization has or agency has its own return to work policy and protocols. And in regard to isolation as well, after being isolated, every organization has its own return to work policy as well regarding that too. Next page. I won't go through this verbatim. I apologize. It's a little small, but again, what would have to happen is typically the employer is going to maintain confidentiality in terms of who's sick. They're going to be helping out in terms of contact tracing. They will contact the local health unit. They will look into those who were exposed. So I was dealing with an outbreak at an agency where they had two clients that were positive for COVID who did come in when they were positive that no one knew. They did have a fever. There are two or three other people that were in close contact to this person. So we did contact tracing. We made follow call-ups or calls to those people, notifying that they've been exposed to someone that was positive for COVID without telling their names, and that they should look out for signs and symptoms of COVID. And then lo and behold, a couple days after, before coming into the facility, two of them had fever, one had a runny nose, and we kept them isolated as per protocol, COVID protocol. So those are some of the things that the employer will be doing behind the scenes as well. Next page. IPAC measures, the fun part. So we know we're in outbreak. We have a few people that have been isolated. What do we do now? So what I'm going to tell you right now, what I have here is a mishmash of what we should do as community support services agencies, mixed in with what long-term care homes or retirement homes should be doing too as well. So we know we have something called routine practices, which is based on the assumption that all clients, everybody, all clients, patients, or residents, caregivers are potentially infectious, even when the person's asymptomatic. And specific standards of care should always be routinely followed to minimize these risks. So during an outbreak, you have those positive cases. There's going to be our regular routine practices, which we normally deal with, but there's going to be additional precautions that are going to be added to as well during outbreak. So some of these IPAC measures that should be applied are, in our regard, PCRA, so point care risk assessment. Our community services or community nurses, PSWs, are going into homes. This person's been assessed. Do they have COVID? They do have COVID. Okay, what do we do? PPEs, additional precautions. What kind of additional precautions do we put on? Is it contact, droplet, or airborne? We assess whether or not we're going to be using gowns, masks, gloves. What's the level of support that am I providing? Am I going to this person's home to drop off maybe the mail or drop off some food where I'll probably just need a glove and a mask because I'm not seeing that person? I'm just going to the front door. Am I going to this person's home to provide direct care and supports, vaccination, immunization, a change? Okay, maybe shower. Okay, you know what? This person's positive for COVID. I'm going to have to wear PPEs. Additional precautions are going to be needed for this person. So PCRA, PRA along the same lines as well. Understanding hand hygiene. Now we're in outbreak. We have to make sure we're washing our hands frequently. If you're in a long-term care home or institution or within a CLS, I'm going to be washing my hands quite frequently. I'm going to be using ABHRs quite frequently as well to ensure that my hands are clean. Am I using the 4 moments of hand hygiene? Disinfectant, cleaning our hands, or hand hygiene prior to entering the person's environment. Hand hygiene after leaving that person's environment. Hand hygiene prior to doing an aseptic technique. Hand hygiene after being in contact with this person's bodily fluids. That has to be taken in assessment as well. PPEs, gloves, gowns, mask, and eye protection. Do I need it? Again, through the PCRA, we're going to determine I'm going into this person's home. Are they positive? They're not positive. Okay, they're not positive for anything. Are we suspecting or are they probable case of anything? During our assessment, we said no, the person's still feeling fine. There's nothing wrong with them. Okay, I don't need PPEs. The person is confirmed or suspect has some type of respiratory, even gastrointestinal illness. Well, guess what? I'm going to have to wear some kind of personal protective equipment when going in. So what am I going to be using? Again, assessing what level of support I'm going to be providing this person will determine what type of PPE I'm going to be wearing. Again, during outbreaks, environmental controls. So that's structural design, placement of ABHR, shared rooms. Okay, we're dealing with an outbreak here. If it's in an institution or within a long-term care home, retirement home, it's structural conducive for having this as a locked unit because all the cases are on the fourth floor. Are they sporadic? Placement of ABHRs are also some of the environmental controls that we look at during outbreak as well. Does this person have ABHR, alcohol-based hand rub station, and a point area of care by their bed as I enter the room, as I enter their home? Do I have ABHRs on me as well as I enter this home, being that this person's positive for a reportable disease as well? Is it a shared room? Is it a shared home? Are there people in this home that I'm going to be in contact with who have been with this person who's positive, who more than likely are going to be positive themselves, but I don't have too much information pertaining to them because I'm coming in from outside. I'm a personal support worker or a nurse coming in from the community. That has to be assessed, and those things have to be known prior as well. Uh, Administrative controls, policy and procedures for staff education or immunization policy. Do we have an immunization policy in play? So that I know that, hey, you know what? I'm walking into a home where a person has COVID. I've been vaccinated. I'm somewhat protected. I shouldn't say somewhat. I am protected. There is some form of protection. Those are some of the rules and policies that have to be implemented and ensure they're implemented during a outbreak. Do I need to promote staff education? Hey, you know what? It's outbreak time. We're running into outbreak. We have something going on. I find some of the staff are a little overwhelmed, and I think there's some misunderstanding in terms of proper donning and doffing, ensuring that staff are understanding how to don and how to doff properly, because that in itself can put them at risk for other things as well. And then engineering controls as well. We spoke about this earlier on. I saw something just popped up just now. I will answer your question shortly in a bit as well. ABHR installation, point of care, physical, mechanical measures, and sharps containers location. Those are things that we take in consideration during our outbreaks too as well. Next page. IPAC interventions to be used in additional routine practices to protect and minimize the risk to the staff, client, resident by preventing transmission of infectious disease to others. So these are all dependent on the type of infectious diseases that we're dealing with. So depending on what we're dealing with, we're going to either use droplet contact or airborne precautions will be implemented to help protect us. If a client, patient, or resident develops symptoms, additional precautions shall be implemented immediately. So we're going to isolate them. If someone's sick, isolate them in an isolation room that we have dedicated for just isolating our clients until someone can come back and pick them up. With our ADPs, in regards to long-term care homes or retirement CLS is a little different. You're going to isolate them in their rooms. Um, Again, isolate immediately and implement additional precautions. Ask client to remain home if ill. The client is at home, or is a client that is housed, and they have a reportable disease. It is, I mean, their doctor or their GP is definitely going to tell them, but as well, it's good for us to remind them, hey, you know what, you're ill, you're positive for COVID, RSV, influenza A. It's a good idea that you stay home during your period of communicability while you're infectious, and then come out of isolation when maybe the fever breaks or you start feeling better. And then also placing signage outside clients' homes. So with our cases, with ADPs, there's no need to do that at all. In terms of those who go and visit homes, we know which room that person's in. So we know that, hey, you know what, if the person's bedridden, they're in that room, they have COVID, I'm going to be using my gloves, my gown, and my face shield or my mask as well. N95 or medical N95 mask respirator preferred because this person's positive for COVID. I'm going to don either outside the home or I'm going to don in a special area of that person's home that would be considered clean. After my assessment, I would have known that during my assessment, and then I go into that room to provide the supports. And those are some of the additional precautions or things that should be implemented. Next page. And again, as we talk about precautions, this is something we should all know what contact precautions are. So contact precautions are any type of reportable disease that we can acquire infection from based on contact with the person or contact with an inanimate surface. Um, Gloves, gowns should be worn. Come into direct contact with client, patient, resident, or other environment. You should be wearing gloves and gowns for sure. We deal with droplet precautions, facial protection, medical mask, eye protection, and when we're dealing with things that are airborne, chickenpox, tuberculosis, measles, which are highly infectious. And when I say highly infectious, you could be positive for measles right now, leave a room. 2 hours later, someone walks in that same room and they could pick it up from you very easily to get measles. And in that case, you would wear airborne infection isolation room, which would be a negative pressure room. Fit tested N95 respirator for airborne pathogens would be used as well. And it was just some of the resources if you want to find out more about this as well. And as promised, I will get more into additional precautions at a few of our additional seminars that we have and get into it a little bit more in terms of the process and the procedures to do donning and doffing and things of that sort. Next page. And screening. The reason why I put screening on here is we had an outbreak at one of our organizations a while back, and these are one of the methods that they initiated during their outbreak. Anybody that had tested positive during rapid antigen tests for COVID were kept home, and that was staff and clients as well. And I just put a little blurb here in terms of what screening can be, which is in persons, could be signs posted. Yeah, gotta ensure you have enough supplies for screening if you have them screened at the organization as well. So you're going to keep your staff trained and protected. PPEs, cleaning and disinfecting wipes around the area, maybe ABHR as well. Train screening staff so they understand how to do it if they're going to be doing or they're going to be sending it home to the client to do it themselves or the staff members. Frequent reminders on how to do it properly and how to wear PPEs. And if you're using rapid antigen screening as well, the rats, how to use them properly and to check for expiration dates. I get quite a few questions on that, which is great, which means everyone's using them still. Based on the type of rapid antigen test that you're using, some of them way past their expiration date can be reused or can be used, I should say reused, can be used, which is perfectly fine. And if you have any questions, as usual, reach out to me. I'll send you the information where you can check as well and you can move forward with that as well. Next page. Administrative measures, which is out of IPAC measures for outbreak management. So again, this is a mishmash of our community support services agencies and long-term care home stuff inside there. So ensure the organizational risk assessment is conducted to determine which controls are already in place and which controls need to be implemented. And these includes administrative, environmental, engineering controls. So ensure adequate availability of all supplies. So we have to ensure that we have enough hand hygiene products, enough PPEs, enough linen, enough cleaning products and specimen collections supplies. If you're a long-term care home, you should have that for appropriate departments as well. So this should all be assessed during the outbreak. And a lot of this, if you are a organization that has long-term care home or a congregate living setting, this will be assessed during your OMT meetings when public health does come in. For those of us who have ADPs, who traditionally aren't being supported in this regard by public health, that's something we'll do ourselves to ensure that we have enough supplies just in case of outbreaks. And then again, as well, administrative controls is consult with your IPAC lead or OMT, myself, or maybe someone within your organization, your IPAC lead within your organization, in regards to cohorting staff as well. So typically, one of the criteria, one of the things that we do during outbreaks is we cohort staff. What I like to do traditionally, if it's in a institution, I would take the staff, few specific staff members in the affected area, and have them cohorted to just working with those clients and just those clients alone. I know sometimes in community support services agencies, when we do home checks, we have specific nurses or staff members or caregivers that provide support to just those who are affected. And that's the best way of doing it because you're minimizing that risk, that staff member going from a person who's infected to someone who's not affected now. And if there's any break in barrier of infection control while providing supports to this person, then you stand the risk of also pushing it on and infecting or co-infecting somebody else. So a lot of times when we have outbreaks, regardless of what institution or what organization you work at, this is what we try and tend to do with our staff members, our caregivers, is provide cohorting of them as well. Ensure policies and processes are in place for rapid deployment of antivirals. So those of you who are CLSs or congregate living settings, you have that opportunity to ensure that there's antivirals out there, enough antivirals. And again, with antivirals, they just lessen the period of infectivity or of period of not incubation, period of communicability. It lessens it and it helps the person to come up fairly quicker. Just as traditional antivirals do, just like Oslamivir, Tamiflu for influenza A and B. When you start introducing these antivirals, the chances of you seeing any other reported cases should be reduced to at least 1 or 0 within the next 3 to 4 to 5 days after initiation of antivirals. So they do, excuse me, so they do work. Next page. Restrictions for clients, residents, and patients. So these are our caregivers, our PSWs, our staff members, our patients, our clients, our residents as well. So when providing outbreak management recommendations, again, public health units, when they're involved, they assess the risk of non-compliance to outbreak control measures in general client, patient, resident population. So generally, public health units discuss outbreak control measures, which we're talking about right now, and implement those measures. With ADPs, we are forced to assess the appropriate measures by ourselves while understanding our individual agency's ability to comply. So um, a lot of our agencies have different supplies, they have different abilities, so we have to ensure that we can comply with some of the control measures that we're implementing within our organizations during outbreaks or whenever we figured out that there's a unusual amount of infected clients or patients or residents within our organizations or within our long-term care homes or CLSs. What we like to do is in cases like this, we're going to limit visiting hours. If it's a facility, you're going to limit those visiting hours. If it's a home, I mean, you're still going to go and give them supports, but sometimes you may even recommend, hey, you know what? You got two or three people who are ill in this home. I would limit the amount of people you have coming to your home or visiting. If we're a community support services, ADP, you know what? You're sick, no one's coming here at all while they're ill, so no, you cannot come and visit, or no one's allowed in our programs right now until things die down. Limiting the number of clients or patients or residents with whom visitors has contact with, requiring anyone providing direct clear care to wear necessary PPEs. So, if, hey, you know what, Dale? Um, we know that we had five ill let's say staff, let's say five ill clients. The two or three other clients at their table are perfectly fine. Can they come back to the facility or can they come to the facility? Can remain open for these? Yes, you can remain open. However, there's certain control measures. You're going to ask them to wear a mask to protect themselves and to protect your staff. And again, you're going to be looking out for signs and symptoms of illness. Posting signs at entrances of your facility or your affected area units, donning and doffing outside homes or in special rooms. So these signs are going to notify, hey, you know what? This program's closed, or right now we're in a bit of an outbreak. The program's closed, just to give everyone an idea that they are not to come in, and that things aren't status quo right now. We're in outbreak. If you're again, your institution, non-essential visitors during outbreak periods to client's home or agency is usually restricted. Limiting communal dining activities and day programs, again, usually restricted and closed. And again, our biggest thing is if you are in outbreak and you're like, hey, we have an abnormal amount of ill staff and clients, a lot of them are positive for COVID. The best thing to do is to notify all the stakeholders and notify families, notify the staff, and have the staff notify their families as well. And again, telling them to look out for any signs and symptoms that are indicative to whatever the organism is that's been ravaging our facility or our organization as well. Next page. Implementing universal masking in the suspect areas. Again, universal masking, you're going out into a facility or into a home where you know something's going on, wear the appropriate mask as well. If you're just doing just very light supports, understanding what is needed of you. Asymptomatic clients, residents, or patients outside the suspect outbreak area are able to participate in daily activities. Status quo for them. Symptomatic people are to remain at home or in their rooms. And again, additional precautions are required when entering a symptomatic client's, patient's, resident's home or room as well. During a suspect outbreak, symptomatic clients, residents are recommended to receive treatments such as physiotherapy and occupational therapy in the rooms instead of common areas. So if these people are, if this person is symptomatic, again, as I mentioned already, you're going into their home, they can still receive physiotherapy supports. Anything that is needed should be given to them. But again, taking consideration that you're going to minimize the risk by wearing PPEs when dealing with this client. Symptomatic clients will be allowed to attend medical. So again, anyone who is in any form of medical need or they have any important meetings, medical appointments, they are still allowed to leave and go to these medical appointments. The only thing is they'd have to call ahead. notify the facility that you're coming from a infected home or infected long-term care home. You're symptomatic, but these are the precautions that you're going to be taking when you're sent out, and these are the precautions that I will be ensuring that this client maintains when in your office. For respiratory illness, if a client, patient, resident chooses not to wear a mask or is unable to safely wear a mask, caregivers, healthcare workers, staff should review the PCRA and adjust the PPE accordingly. And it does happen. They don't want to wear a mask. They can't tolerate the mask. Then you, as the caregiver, healthcare worker, staff member who's interacting with this person, be it indirect or direct, will ensure that you're wearing the proper PPE for that task that you will be providing to that person. Next page. Additional considerations for accommodation may be supported for safe movement of the client. A lot of cases you deal with people with dementia. If you're a long-term care home, it's hard to keep them in the rooms. It's fine with them coming out. Just ensure they're washing their hands. Try to get them to wear a mask. Try not to have them meet or directly have any contact with anyone who isn't sick. So it's very difficult. As well as ensuring that at all times when outside of their home or room, putting on a PPE using ABHR, physical distance, and avoiding touch surfaces is adhered to as well. And then also minimizing contact with isolated people that are ill was the best thing to do. If that person wants to go outdoor during the outbreak or they want to be outside, we have no problems with that whatsoever. That's perfectly fine. Next. All right, question period. Here we go again. This is our last one. So, my question to everyone is, what are the 3 types of additional precautions? Are they droplet, contact, and airborne precautions, liquid, hard surface, air precautions, or taste, touch, and feel precautions? All right. All right, perfect. We had 19 responses and 100% correct. So the droplet, contact, and airborne precautions are the ones that we use. Additional precautions as well. But correct. Thank you so much, guys. 100%. And next, restrictions on affected agencies, homes, units, and sites. So restrictions on affected agency units will depend on the type of outbreak, severity of the outbreak, and the risk of non-compliance. Restrictions will be determined by the outbreak management team established and reviewed daily by direct OMT representatives. And restrictions will always be clear, concise, and assessed regularly to ensure that implementation is working to minimize risk. So during outbreaks, what I like to do, my style over the last 25 years has been, there's an outbreak in an organization, community, a home, anywhere. I like to go there regularly, every other day, every few days, just to double check and to make sure that the control measures implemented are still in place. And that's all we ask, that if you have an issue within any of your ADPs, if you're closed, making sure that no one's coming in and that you're closed, ensuring that the areas have been cleaned and disinfected properly and with a medical grade disinfectant, and to ensure that you're assessing the staff members and the residents or clients who have been at risk or who have been in contact with those positive cases as well. So just a way of ensuring that things are working and being done properly, and that those checks have been completed. That will minimize that risk of outbreak getting blown out of proportion as well. Next. Groups and social activities. That's a big one for us. So symptomatic clients, patients, residents, or those on additional precaution are not recommended to participate in any in-person group or social activities with other clients, patient, residents, and institutions should discontinue group activities in affected agencies or units. So we have an outbreak. Things are getting out of hand. We have a lot of positive cases. Group activities with symptomatic cases are not recommended at all. And I like to say is pretty much an IPAC requirement. If you're symptomatic, you're ill, you have COVID, influenza, any type of respiratory illness, even gastrointestinal reportable disease, you should not take part in any group activities where you stand the risk of infecting others. Symptomatic clients also or those additional precautions, they continue to interact with essential caregivers and visitors. This includes going outdoors and participating in one-on-one activities as long as additional precautions are followed. So yes, so if push comes to shove and this person, again, you're supporting them at home, which is perfectly fine, as a caregiver, PSW, healthcare worker, nurse, there's nothing wrong with you participating with certain activities outside as well. And if it's a one-on-one where this person is needed, then again, as I said, you're going to ensure that you meet additional precautions, that you wear the appropriate PPEs when handling this person. You're going to provide a PCRA and understand what you're going to be wearing when you're dealing with direct care to this person. And again, one-on-one visits with essential caregivers or visitors may continue if additional precautions are followed, as I said. Next page. Visitors and essential caregivers. So general caregiver visitors should postpone all non-essential visits to clients within an outbreak area for the duration of the outbreak. Essential caregivers should direct, and again, if this is a long-term care, direct questions to reception desk. With us, we're going in, we're the caregivers, we're the PSWs, nurses who are going into the facilities. This will be all assessed prior to the visit as well, determine whether or not this person really needs a visit, and we'll visit based on what we've assessed. If essential caregiver is symptomatic, they are recommended not to enter the setting as well. So anybody that is ill, they don't even have to be a part of the outbreak. Just so you know what, listen, it's a respiratory outbreak that we're dealing with. I got gastrointestinal outbreak or a gastrointestinal disease, say Shigella or Salmonella perityphi or something that's highly easily infectious. Um, I'm not to go into that person's house. I'm ill as well. Anyone who's symptomatic, any type of illness should not be going into anyone's home to provide support unless it's a staffing issue like what we dealt with back in COVID times. Then there's going to be a couple of checks and balances that have to be assessed prior to that person going into that person's home if they're positive for anything. So again, that's something you would assess as part of the OMT team. And I know the province does give out certain criteria, certain things, a certain checklist that has to be adhered to prior to doing that as well. Next page. Um, it's, as well, essential caregivers are not recommended to be restricted from visiting their loved ones, but limits may be required and will be assessed on a case-by-case basis. Again, agencies to contact family members and advise them of their relative's illness if it's an institution, and agencies should have dedicated areas for ill clients until families are able to pick them up. So with our agencies, um, and we're in regards to visitors or essential caregivers coming in to pick up our staff or pick up our clients, if that person's ill, they're put in the isolation room, they're contacted, they'll come, that caregiver is to go directly to that room, pick up that ill client, and then safely put them in their car or into transportation and head home with that person after that. Next page. All right, so just a general healthcare worker staff outbreak control measures, including volunteers, students, and physicians as well. So healthcare workers should monitor themselves for signs and symptoms. Everybody at work should be monitoring themselves for signs and symptoms. Anyone who's symptomatic should self-isolate at home and not go to work and report their illness to their employer as well. Employers also have a duty to report, which we all know under Occupational Health and Safety Act, OHSA 6, Ontario regulations. I want to get into that. Healthcare staff who also develop respiratory symptoms at work want to perform respiratory hygiene practices and then decide or go home as soon as possible. For respiratory illness, staff should immediately leave and be directed to self-isolation at their home until symptoms have been improved for 24 hours and no fever present. So we all know this criteria that we must follow based on the new COVID protocols as well. And typically you're infectious for 10 days. So if you're feeling better after 5 days, no fever, you decide to go back to work, you are to wear a mask as well for another 5 days while at work and try to adhere to and minimize all risk and try to minimize contact with clients or with other staff members until that 10th day as well. Next page. Let's get into gastrointestinal symptoms as well. And again, as I said, it doesn't matter what type of illness you have, respiratory, gastro, you're recommended to perform hand hygiene and leave work as soon as possible if you're ill. Gastro is a little different. It's 48 hours symptom free. This period can be modified if the causative agent is known. So if I know what it is that you have, Salmonella typhi or Shigella soni, or one of those really nasty ones, we'll know the incubation period and deem whether or not this person can return back to work. If it's anything gastro, where they're vomiting and diarrhea as well. Another thing as well, as we mentioned, we're going to cohort healthcare staff to care for asymptomatic clients, patient residents before symptomatic. So if you're in a situation where, hey, Dale, you know what, I'm a community support agency. We go out to homes. I can't really cohort my staff to just be taking care, just, a particular staff member taking care of just the ill clients and the ones taking care of the asymptomatic, taking care of asymptomatic clients. It's perfectly fine if you have that one person visit other people. If it's logistically feasible and makes sense, if they can go out to those who are not ill first and go to the ones who are ill after, that makes a lot of sense. And that again minimizes the risk to those who are not affected. Um, Again, educate volunteers on the importance of hand hygiene, routine practice, and additional precautions, and including a PRA. Symptomatic volunteers are recommended as well, like anyone else, not to enter the setting and not to go to work. And volunteers are recommended to follow the same PPE recommendations as all healthcare workers, caregivers, staff, anybody out there as well. Change. Environmental cleaning and disinfecting. So, this is a heavy part of outbreaks, and I always say this is the most important part of outbreaks because a lot of times, depending on the outbreak, depending on the organism, this can single-handedly decide whether an outbreak is going to be a long one or a short one. If you have a really good cleaning, a really robust cleaning and disinfecting policy, and a really good environmental services staff who keep the areas clean and disinfected regularly, chances that the outbreak will last long are minimized, being that the air is clean and disinfected properly. You've minimized that risk. So clean and disinfect common areas at least once daily for low touch surfaces, shelving, windowsills, white message boards, things of that sort. And then during outbreaks, it's twice daily for high touch surfaces. That's door handles, knobs, um, handrails, phones, elevator buttons, treatment areas, and immediately for any visibly dirty surface. Anything that you see that's visibly dirty during an outbreak, get that cleaned ASAP because that is going to more than likely be your source. If it's a contact organism that we're dealing with as well. Next page. So non-critical medical equipment should be clean and disinfected at all times and all in between every patient. And if you're unable to dedicate the equipment, again, it should be cleaned regularly, clean and disinfected. Staff equipment should be cleaned and disinfected at least twice daily or when visibly dirty, and ensure staff are educated on cleaning and disinfecting procedures, following clean schedules. So this is something that we should be doing regularly with staff at all time, ensuring that they understand the procedures and the policies that are implemented for environmental cleaning. If areas that are not considered common areas do not require enhanced cleaning and disinfection, but they should be cleaned as well. Private offices, administrative offices, and areas. We know within our organizations, we do run into issues where we have outbreaks where it's staff members. So in those cases, those offices should be cleaned and disinfected regularly at all times. Use appropriate PPEs and donning doffing methods for cleaning and disinfection practices as well, and ensuring that upholstered furniture, rugs, or carpets contaminated with bodily fluids such as vomiting, diarrhea, are difficult to clean and disinfect. So you should be cleaned, steam cleaned as soon as possible at all times. What else can I tell you? Soil linens are recommended to wear gloves and gowns if there's a risk of contaminating their clothing, and additional precautions may be needed to be adhered to depending on the organism as well. And if laundry machine has been used to clean soiled vomit, diarrhea, laundry, always remember to run a bleach cycle prior to putting in the cleaner clothes as well. Next, and again, simple process for clean disinfection. I know everyone does this. I've gone to a few agencies, quite a few agencies. I've discussed many environmental policies with everyone out there, and everything. There's something developed already, so we all have a checklist that's already put in place for monitoring for high touch services. We also ensure that these areas are cleaned properly. We also had posters reminding employees to frequently wash and clean and wash their hands is the biggest one actually. So everything's being done perfectly fine in this regard. Clean physical beer. So if you still have physical barriers within your institution, which a lot of places I think have taken them out, make sure those are cleaned regularly as well. You walk into some of these grocery stores and even some banks where they used to have it and they still had it, and you just see all this spray on top of the plexiglass that's showing me that you're not cleaning regularly. That should be cleaned regularly at all times. In the cars, the other day I had a discussion with one of our organizations pertaining to plexiglass in the car. And one of my things to her was that, you know what, ensure that's cleaned regularly as well. You're having multiple visitors, multiple people being transported regularly. They're going to be touching that. Not everyone has the best hand hygiene procedures. It's good to have those cleaned at all times as well. Next page. And again, ensure proper cleaning. Chemicals are being used. Again, as I always say, it has to ensure you have a DIN number. That DIN number is going to tell me that it's been looked at and been approved by Health Canada. And without that DIN number, it won't be considered as a medically grade chemical for cleaning and disinfectant. So always pay attention to that. My biggest important one that I always stress everywhere where that I discuss environmental cleaning is contact times. Doesn't matter about anything. You can take a bottle of alcohol and throw it on top of something and wash it off immediately. That's not going to clean or disinfect that area at all. It needs a specific contact times. And when you read the bottles of the chemicals that we use for cleaning, there's a contact time inside there. And typically, you want anything less than 5 minutes in healthcare because we don't want to be standing around that long to ensure that that's going to stay wet for 10 or 20 minutes. So 5 minutes or less is what we're looking for contact times for healthcare grade chemicals. A lot of places out there would have 3 to 1, which is the standard I find out there as well. Um, change. And this is just an example of some of the things that we use, like cell intervention, which is really good. So 1 minute, I think this is accelerated hydrogen peroxide, H2O2, yep, 0.5 percent to the volume. Very good disinfectant. Comes from Diversity. I'm not pushing Diversity, but a very good accelerated hydrogen peroxide product. Next page. And we have this one, which is called Excel 5TB. Again, it's tuberculocidal, which means it kills everything. It's a 5 minute disinfectant. The other one I find much better, easier to use. And again, I use this in hospitals. When I worked at a couple other homes, or a couple hospitals downtown, we use these types of disinfectants for specific rooms. I might have someone who would a multi-drug resistant pneumococcal issue, and then I would ensure that certain disinfectants are used in their rooms to ensure that everything's clean and disinfected properly. So this is a really good one. Diversity XL5. It's again, as I said, it's a 5 minute contact disinfectant. Next page. I did some program space routine inspection. At one time, I used to get a lot of calls about how do I monitor that the areas are clean and disinfected? What do I use? And I said, it's just a basic, quick program space routine inspection thing is what you need to use just to ensure that the times are stated on it, where they've wiped down, and just an initial. That simple. And it's just a good example from one of the institutions. Infection prevention, workers' health and safety. We're going to go through this a little brief because we've already touched upon this already. Yep, next page. Yeah, so general guidance is encourage employees to get vaccinated, which is the biggest thing. Developing strategies to minimize exposure to reportable disease. So this is going to be a part of our outbreak management plans as well. Provide staff training on required public health measures. Again, as I stated, brief overview how to handle outbreaks is an outbreak management team checklist that not every long-term care, every public health agency has. A lot of times I like to look at that, things that are not they're not really relatable to us. I kind of nix and don't look at it, but it's a great form to use when you're in a situation where you think there's an outbreak and you need to understand what is it that I need to implement to minimize the risks. So training a staff on that is great. Ensuring staff passively screen daily with reminders. So again, hey, I'm not feeling good. Don't go to work. If you're not feeling good, don't go to work. You're not going to be a trooper. I'm not going to look at you as, hey, you came to work because you're sick. You're a dedicated worker. No, no, no. If you're sick, stay home. Because if you come to work sick, I get you're dedicated. I fully understand. You know what? That's great. I really love that, but at the same time, you're putting other people at risk. If they get sick, they're gonna end up staying home, and it just cascades down. So if you are sick, stay home. Provide mask-friendly environments for those who choose to wear masks. So as we know, masking policies have all been revoked. Um, I know during outbreak season, the province may initiate again a masking policy for long-term care homes or for any retirement homes during outbreak season, so that may occur again. But for the most part, the masking policy through the province was revoked. So just ensure that you have a mask-friendly place for those who want to wear masks. Because a lot of times I do see people out there wearing masks, and that's an indication to me sometimes is that that person probably has some form of comorbidity where they don't want to pick up anything because COVID is still out there, or that person's ill and they're protecting the people around there. So, please ensure that there's a mask-friendly environment for them. Schedule frequent cleans as well. Disinfection of high traffic touch items, surfaces, and washroom. Inform staff, clients, and customers about actions you're taking to keep everyone safe. And plan to implement protocols to keep staff, I shouldn't put customers, but I want to say clients and patrons safe at all times while they're in our organizations too as well. Next page. And that is it, everybody.